How are you controlling it?
Yeah, I mean, it's an interesting question, and every time I have to do continuing medical education or do a renewal of a license, there's a whole opioid educational curriculum, and it's interesting because I've operated in 2026, it'll be 30 years that I've been operating, and we've always used short-term narcotics as a way to treat surgical pain. What I do is called an ERAS. So it's early recovery after surgery. And it's a combination of ondansetron for nausea, an anti-inflammatory, and you can sub in different anti-inflammatories. One's used routinely are celecoxib or naproxen, and you can choose whatever. The other thing you want to do is control for neuropathic symptoms because neuropathic pain's a really difficult problem for patients. And if not appropriately addressed, and we try to do everything up front. We don't try to respond to it after it's already happened because it's more problematic. So we treat all of our patients up front with a dose of gabapentin or pregabalin, and then post-op, there is narcotic available if needed, but intra-op, so during the procedure, nerve blocks are done with a combo of short-acting and long-acting local anesthetics. So we use different combinations, like anesthesia does specific nerve blocks with ropivacaine, and then we do specific nerve blocks with a combination of basically regular Marcaine and then liposomal. So the short answer is I don't do anything as I was taught. I do everything to avoid what you're describing, which is problems with post-op. So it's almost universally unheard of for me to have people ask for more pain medicine. And if they do, then we have to be alert to like that's somebody with a metabolism issue, because it's very rare that I would have somebody have an addiction type issue.